So after a very different deviation from the topic, we'll be focusing back onto academics. Although there was a lot of academics in Sudhir's talk, but then mine gets traversed. So what I'm going to talk about is truly awake spine surgery, where the surgery is performed under local anesthesia. A few years back, in this very hall, perhaps, we had all gathered to hear a talk by foreign faculty on awake spine surgery. And that time the concept of awake spine surgery was not so well defined as has been defined today by Mahesha and the anesthetist, Dr. Padma. So we were all wondering that how does this guy do it and what sort of a cocktail does he use. And so when he began talking, we all realized that, oh, he's talking about spinal anesthesia. And that never was thought of because we were all thinking that there may be something different that he must be doing for awake. And this is what we routinely do for our simple microdiscectomies, decompressions, and sometimes even TLIFs. And this spinal anesthesia, surgeries under spinal anesthesia has actually increased during the COVID period because none of our anesthetists were willing to give general anesthesia. So what I am sharing here today are two of my cases where neither general nor spinal was possible and I had to do them under local anesthesia. So the first case was an elderly female of 94 who had ankylosing spondylitis, and he was also a known case of interstitial lung disease. She was on long-term steroids and she had a history of fall with this sort of a image. She had ankylosing spine and she had hyperextension at the D10 vertebrae. Although she was able to continue ambulation initially, she developed paraparesis later and present to me thereafter. Her lower limbs were power 2/5, although the bladder bowel was intact. And he was unable to lie on in the supine position and required positioning only in the lateral. A CT scan again also shows that there was a 3-column injury, complete 3-column injury at the D10 level with hyperextension. And on discussion with the pulmonologist, he was absolutely categorical that we cannot give any general anesthesia to this lady, otherwise she'll definitely go into a ventilator. And there's no way he can guarantee that she'll be able to be wean her off it. The question was whether spinal was possible or not. And so the anesthetist was a little bit scared that even if the spinal would go, this would go, we may not be able to achieve an exact D8 or D9 level, and then it can be a soup as well. So we decided to consider this patient under local anesthesia. I began to wonder what lignocaine, xylocaine, ropivacaine, and all was the anesthetist was left with the conscious sedation part. So again, the standard procedure of putting these ankylosing patients on the pillows and skin markings, I injected the local. And again, this is what I gradually began to infiltrate the muscle and did the percutaneous fixation. So the epidural, the paraspinal block, what the madam had suggested today, that also could have been instituted here, but unfortunately I did not go into that aspect that time. So these are post-operative images of that same patient where I was able to do a percutaneous fixation above, below, do a percutaneous vertebroplasty, and I had to put in a curved rod to accommodate her kyphosis at that point. She was discharged to home. We started her onto teriparatide. She recovered partially because decompression was not possible in this scenario. But she did recover some power because of the stability and began to sit comfortably. She survived and remained pain-free for about 8 months post-op. So then going on to my second case, she was a relatively younger lady, about 75. Again, same history of difficulty in sitting and walking. She was almost homebound for a year and a half because of the COVID scenario, and she had extreme difficulty in changing postures and getting up. The dorsal lumbar spine was quite tender with girdle pains. Her neurology was actually better than the previous lady with some proximal weakness, and bladder bowel was intact. Again, the same history of interstitial lung disease, low pulmonary reserve. GA was unfortunately not possible in the same case. So this is the patient here. She had D11. You can see at the top, it's almost completely collapsed vertebrae here, D11. And there was some marginal opening on the sitting at the supine X-rays. This was our MRI. Again, there was this Kummel sign visible with some compression by the ligamentum flavum at the upper end. So again, the same procedure was performed. percutaneous wires, insertion of screws. So this is a video that I took during the second case because I was a little bit more informed in the second case. You can see the xylocaine and the local infiltration peripherally around the guide wire. And I've already put two screws in. I'm putting in the third and the fourth screws now. At this point, it's all being performed under local anesthesia. And the video will shift to the patient where she is lying prone without any tube in her mouth. So then we were able to do again a percutaneous vertebroplasty in fixation above and below and stabilize the vertebrae. So this lady began ambulation at 4 weeks. She got teriparatide started and remained ambulatory for 9 months post-op. And she was really quite pain-free, although she did have some arthritis of the knees. But we just lost her recently, about a month back, but she did quite well for the last, 9-10 months she survived following the procedure last year. So the literature, if we go back to the literature, there is evidence of local anesthesia surgery being performed under local anesthesia way back in the 80s and 90s, where they used to do cervical spine surgeries under local and use the patients to, respond for the neurological assessment. But this is now a bygone area. We no longer do them now. There is an article by Jian Shen in the World of Neurosurgery published in July 2019, where they did endotelif with full endoscopic bilateral decompressions under local anesthesia and conscious sedation. This paper has, however, focused more on surgical techniques and has little bit, there is a gap about the details about the local, whether part of the procedure was done under a local or under general anesthesia. So percutaneous vertebroplasty with fenestrated screw fixation with cement under local is technically a truly awake spine surgery according to me. It's possible to do them in selected individuals with extreme degree of counseling. No literature support is available for this kind of cases. I had to do what is the Indian jugaad, which is the need of the hour in such cases. And it is an example of just what is feasible and what should be done only in extraneous circumstances. Thank you.